Good morning, everyone. It's a privilege to join you today on behalf of Haleon as we open Pain Takes the Nation, the State of Pain key event during National Pain Week and the official launch of Chronic Pain Australia's 2025 National Pain Report. At Haleon, we're guided by our purpose, help with humanity. That means listening to the voices of people living with pain and supporting initiatives that turn those experiences into action and system-wide change. You may know us for trusted brands like Panadol, Voltaren, and Advil. But what defines us is our deep commitment to community, equity, and better outcomes for those most impacted. This year's report makes one thing clear: pain takes, from individuals, from families, from workplaces, and ultimately from the nation itself. But if pain takes a nation, then the solutions must be national too. The real question is, how do we respond? Not just as individuals, but as a system, as a society, and as a country that values the well-being of all its people. Thank you to Chronic Pain Australia for your tireless advocacy and to our panellists for driving this important conversation.
I'd like to start off this forum today with, I'd like to pay my respects to the traditional owners of the land where I am, which is the Darug Nation, and pay my respects to First Nations communities all around the country who disproportionately experience chronic pain among us. I pay my respects to the millions of Australians, the millions of you who live with chronic pain and your families and loved ones, and in particular the volunteers who run and work within Chronic Pain Australia, going into battle on behalf of you, the people in pain, to build support for you. My name is Coralie Wales. I started Chronic Pain Australia in the early 2000s, working with people in pain who I could see were in an environment which was not helping. There was little understanding of how chronic pain works. There was little support for people in pain, and systems were not set up for preventing chronic pain. I have a special interest in health, in preventing people getting sick. So I stay committed to Chronic Pain Australia's mission, which is to help people understand, not just people in pain, but the broader community, and to work with health professionals and other system activists to make a change that brings chronic pain into a health priority. I'd like to start today by we're going to have a discussion today with a number of experts, including people that live with chronic pain. I'm going to go through the results of the chronic pain survey that was yet again circulated. 4,500 people responded to the survey this year. And while there are many things that have not changed, I remain hopeful that with the work and the advocacy of Chronic Pain Australia and the people in the room today, that we're going to see system changes that are going to bring chronic pain into the spotlight. Let's start our conversation today. Now, panellists, I am pretty good at timekeeping. So what I will do is I will step in at 2 minutes and you will, I'm sure, be able to make your points very succinctly in that 2-minute window. But let's start our conversation today with the challenge that most people face before they even get support, which is getting a diagnosis. This year's report reveals that over half of respondents waited more than 2 years to be diagnosed. Even more concerning, 42%, nearly half, waited for over 3 years, and 1 in 10 are still waiting for a diagnosis. They're big numbers. And it doesn't just put treatment off, it doesn't just stall treatment, it costs people jobs, relationships, peace of mind. And when pain is invisible or misunderstood, early intervention becomes a missed opportunity. So let's start with Kate. I'd like to introduce Kate May. Kate is a lived experience, a chronic pain lived experience and mentor for people experiencing chronic pain in her community. Kate, can you tell us about your story? How does delaying a diagnosis impact people emotionally and practically, and what does it mean for their trust in the system?
Thanks so much, and thanks for having me here today. So my story, it's a story that's not unfamiliar for many younger women. It began with pelvic, back and neck pain in my early 20s. along with those symptoms like fatigue and brain fog, without an obvious cause, and I just couldn't seem to shake them. No matter how hard I tried or different health professionals I saw, it just got worse and worse. Over the next several years, I hit a lot of dead ends trying to find answers, support and options. My test results were always telling me I was fine, but I really wasn't. A turning point for me was actually just checking in with a local physio who quickly listened to my story and identified and validated that what was going on really wasn't normal. This is a thing, and there are actually people that can help. This opened up referrals, diagnosis, and options that eventually made a big difference in my life. For me, two of the big game changers were a diagnosis and treatment for chronic migraine, and actually just being able to learn about pain, learn what I can manage on my own, and when and where to seek help for the things that I can't. 2 years ago, I set up a community group in my local area. We meet monthly, grab a coffee, catch up and chat about chronic pain and what's going on in people's everyday experiences in life. One of the reasons why I choose to speak up about my experiences is because I just see this huge missed opportunity for early intervention and support for people living in pain. It's very clear in my own story, and it's the pattern that I see across the pain community too, and it definitely causes harm. Unfortunately, it's too easy for many health professionals to dismiss, downplay, or misdiagnose your symptoms, and often people just don't really know what to do or how to help. Unfortunately, this over time can really erode your trust in healthcare and make it harder to ask for help again. This isn't unique to medical settings, it stretches across our communities from our friends, family and colleagues. Of course, it's emotionally exhausting and deeply isolating.
Thanks, Kate. I mean, when you don't trust the system, then you don't feel safe. Yeah. I'd like to go to Dilip. Professor Dilip Kapoor, Dr. Dilip Kapoor is a pain specialist and Dean of the Faculty of Pain Medicine and one of the collaborators with Chronic Pain Australia, trying to bring chronic pain into a health priority. Dilip, can you tell me how can primary care and allied health professionals be better trained to recognise chronic pain earlier? And what education reforms are required?
Yeah, thank you very much, Coralie. And it's a great honour to be in this panel here with some esteemed colleagues and also some wonderful friends from the community. When I've listened to Kate's story, Coralie, I'm afraid it's all too familiar to me. And one of the points that Kate's made that's incredibly important relates to the harm that's occurring when people are sitting in limbo with no diagnosis and no pattern. And unfortunately, all too often, there are inappropriate diagnoses that are administered. Sometimes they're mental health diagnoses that are simply wrong. Sometimes they're physical diagnoses that are also wrong. And in terms of one of the priorities in the National Strategic Action Plan for Pain Management, improved pain education, as you know, was one of those. Now, we started a large project on setting core standards for education for health professionals in pain management. We started that a couple of years ago with funding from the federal government. And one of the things that we really wanted to do was to hear the voices of people burdened with pain in the community. So they've been a huge part of our project, and we've done something that on the face of it sounds pretty simple, but it's been incredibly important because it hasn't happened before, and that is we've brought everyone together, including people living with pain, together with a broad range of health professionals, and we've said to everybody, what do you think the priorities should be? But of course, the emphasis has been looking at the experience of people burdened with pain, looking at the problem through that lens, and then reshaping where we think the education priorities should be. So we've come up with a number of strategies that we want to see put in place across the health provider sector, and that will be right from the start of education in pain through all health disciplines. Obviously, from my perspective, medicine's an important part of that because there's a huge gap in pain education in medicine, despite the fact that it's one of the most common presentations in the community. There's almost no training in it.
So Dilip, what you're saying is that you're really taking some active steps in developing some pain education for health professionals, and that's imminent, that you're seeing that being launched very soon.
Absolutely, Coralie. We have the draft
Mm.
strategies. We had a great meeting with the medical colleges. We have other meetings
Mm.
with other colleagues and other groups coming up, and we'd
Mm.
like to see these rolled out later through this year.
That's wonderful. Thanks, Dilip. I want to go to Mark. Professor Mark Hutchinson is a leading researcher and medical scientist specialising in chronic pain at Uni Adelaide. Mark, can you tell me, are there any advances in diagnostic capabilities that would make diagnosis more timely and accurate?
Thanks, Coralie. It's really exciting that we are at a point in the science where we're understanding more about the fundamentals of pain. The problem is we're admiring the problem and not coming up with the solutions. We can do this really well in the research space. So we now know for the first time there are more molecular pathways to pain than there are stars in the universe. Now that is really exciting for us to actually conceptualize, but kind of a nightmare when it comes to actually doing anything about it. Now, that's where we in Australia are actually really fortunate, because some of the best people in the world who are doing pain measurement are right here in Australia. And so there are programs of work that are rolling out now in research land where we're actually asking these questions of what biotype of pain do you have? And can we have a future blood test or other measures that could actually be used in the future? But none of that exists today that anybody can get their hands on. Clinicians like Dilip don't have these tools yet available. And so we're working as fast as we can with the available funding we have in research to get us to that point. But fundamentally, we don't have enough people, time, or resources actually dedicated to delivering those simple things like the equivalent of, if you've got a high blood pressure, you go and get your blood pressure taken. We don't have the equivalent for pain at this point in time.
Thank you, Mark. Well, I mean, and then when you get that research, you've got to translate it rapidly into practice, and that's another challenge, which takes a bit of time. But however, we're working on that. I want to move to, thank you to our panellists for that topic. I mean, the late diagnosis is of great, it causes a lot of grief for people in pain and their families. And if we can move on that path quickly, so much the better. We're going to move on to how chronic pain takes from every aspect of life. It's something that affects our mental health, it affects our sleep, how easily we relax, relationships, work and identity. And my own experience 20-30 years ago was that people's marriages broke down. When chronic pain came in the window, often the marriage went out the door because it is so challenging. So I'm interested in this topic, and I'd like to, first of all, just a warning. We are going to cover thoughts about suicide, and we will display some links to services for those people that might benefit. But it affects every part of life. 74% this year of our respondents said that their mental health had deteriorated since developing chronic pain, and 87% are struggling with disrupted sleep. 87%, wow. More than 6 in 10 are unable to work, and 65% are experiencing financial strain. For many, this creates a vicious cycle that is incredibly difficult to break without the right support. So those supports are often just not there. People like Kate are doing some great work locally, and there are support groups for people all over the country, which you can find out about from our links. But I want to just start with Kate. You're running this support group. What are the people that you know saying about how the disruption of chronic pain, how it disrupts identity, relationships, and just getting on with day-to-day tasks?
Thanks, Coralie. So I recently caught up with my support group and I asked them for their thoughts on, what I could share back about this broader experience of living in chronic pain today. One thing that really stood out from that conversation is how pain just consumes your life. And it's not just the physical sensation or the pain itself, it's the time and energy it takes to management and navigate that. It's a constant adjustment to your daily plans, the mental load of decision making about what to do, what to skip, what you can push through. What happens when your pain fluctuates and your capacity is constantly changing? How do you navigate that? So the impact is not only the intensity of symptoms, it's actually also the time lost, just trying to figure it all out. Another big theme in our discussion was how much energy we spend navigating other people's attitudes and our relationships with those around us and how that changes. The group really felt that there's this constant undercurrent of blame. It often feels like the people that we interact with daily, from our friends, family, peers, colleagues, healthcare professionals, even often very well-meaning, sometimes you can feel like there's people who hold this core belief that if you're still in pain, you must not be trying hard enough, that somehow it's within your control and it's your fault that you're still in pain. So often when we talk about our pain, we feel we're not believed or told we're being difficult or demanding attention. And we get so much unsolicited and deeply unhelpful, often very medically inaccurate advice as well from those around us. Because of all this, we learn to withdraw and not talk authentically about our lives. And as someone that's gained so much from the ideas, connections, thoughts and experiences of people in the pain community, I can absolutely say that this is a huge shame. And lastly, just on that point, I really want to emphasise the ongoing gap in pain-informed mental health support that's available. It's really quite devastating, and knowing how much people can benefit from it as well, it's just not available or able to access. This is something we talk about all the time in community, and it's a really, really hard conversation.
Thanks, Kate. I hear you. I hear you that, you can have a mental health conversation, but often it's with somebody who doesn't understand the complexity of chronic pain. And that's not helpful because it's feeding into, well, why don't you do this and why don't you do that? So I just want to introduce you now to Bernie. Bernadette Smith is a registered psychologist and president of the Australian Pain Society, another strong collaborator with Chronic Pain Australia, working towards getting chronic pain made a national health priority. Bernie, how can allied health support people to escape the vicious cycle that Kate's talking about? That you're working hard, you're trying to pace yourself, you're spending a lot of time managing your pain and trying to stay above water. How can allied health professionals help people escape that vicious cycle, and what needs to change in our system?
Right, thanks Coralie, and Kate, thanks for that fabulous description of just how pain eats into a whole person's, life and how all-consuming it is. The Australian Pain Society, which really represents, the multidiscipline, all of those health professionals from, medical professionals all the way through to occupational therapists and psychologists like myself, and the role that allied health professionals play is really central to helping people break that vicious cycle of pain. And Kate, I think you just did a fantastic job of operationalising what Mark said, that pain is unbelievably complex. It just affects the whole person. And so it makes sense that one-size-fits-all treatments simply don't work. As Mark said, the data sort of tells us that things like interdisciplinary care that really integrate not just medical treatment, but also medical care with allied health expertise, a bit like Kate's example, where things like physiotherapy, occupational therapy, exercise physiologists, psychology, dietetics, pain education, where we go about treating that whole person and not just the pain symptom. Kate, I think you hit the nail on the head. You said that access is something that is incredibly difficult, and I live and work in regional Tasmania and see this day to day in my work. And so, things need to change. People need to be believed sooner. That this story that I hear over and over, that people have to prove that they have pain to get help. And so we need to start listening more and not dismissing the people who are telling us about their pain. Also, pain really needs to be treated as a condition in its own right, not just a symptom of some other sort of condition. And so in that way, we really would benefit from, formal recognition, as you've said, Coralie, in the health system that CPA and all of the pain sector are really working hard for. And funding the whole team, not just a prescription or an appointment. The evidence is clear. chronic pain works best when it is with the whole team. It takes a team. It takes so much from people, and it makes sense that it takes a team to help people, to walk with people. And part of that team is we have to have that person central. And we know that even though that's gold standard care, only 1 in 10 Australians get that truly interdisciplinary care where the person is at the centre, and it's their needs and what's important for them and the clinicians around. So invest early, I think, Kate, or actually, Dilip, you were saying, we need to train all health professionals. That is just incredibly important. And the work that Faculty of Pain Medicine are doing there to really promote that is so important. And
just before you go on, we're limited for time. Bernie, you've made some really strong points to back up what the panel is already saying. And really, the segue is into how pain is taking our connections. And
yes.
the whole problem of chronic pain in people's lives, like Kate, is that nearly 3/4 of the people that we spoke to during our survey said that they felt ignored or dismissed, and 57% said they felt powerless or neglected. And the stigma of chronic pain goes even deeper. 42% said they were judged for their weight. If you lost weight, you'd have less chronic pain. And another 42% felt they were perceived as drug seekers. Oh, look, just give up the drugs. You're getting addicted now. And people still are saying that in a pharmacy, in a community pharmacy, that they can be kind of called out for the fact that they've got prescription medicine that helps them with their chronic pain. So this is sort of prejudice, including in the worst cases, misogynistic sort of responses, aren't just numbers. They represent the daily reality for people living with chronic pain. So I'm going to go back to Mark, who is working with the research with chronic pain, and ask the question, what does the research tell us about the relationship between feeling isolated and living with chronic pain?
So, Coralie, I did not understand until a couple of years ago that loneliness has a molecular and cellular basis in our brains and spinal cords. And that blew my mind from a research perspective. What's extraordinary about the experience that then has for somebody who has the lived experience of pain, that's impacting not only how they're actually feeling at the cellular and molecular level, but also then impacting how they're engaging with their environment. We now know when you go outside and someone says go for a walk, you're not just actually exercising your body, you're actually potentially going and saying hello to someone who's also walking. That's good for you from a brain perspective. You're breathing in and getting exposed to all of the healthy bugs out there in the world, which we shouldn't be scared of. They're actually then helping us and our bodies respond to stress in a better way. What's extraordinary is if we actually acknowledge that when we isolate ourselves from the world, we're actually leading to this really challenging position of our body becomes less resilient. Now, when you have pain, and in the last 12 months, I've experienced chronic pain for the first time in my life after being in a pain research for the past 20 years. You don't want to go outside and engage with people. So there's this vicious circle of, I know it's good for me, but I don't want to do it. So I guess my encouragement here is to acknowledge that loneliness exists. It's at the cellular and molecular level, and by just simply acknowledging that loneliness is there, and perhaps having the tiniest step of going to have a few breaths outside in the sun as the first step to engaging out there, have a go at it, because we're now understanding there actually is a profound biological underpinning to this loneliness that we have in the world.
And of course that legitimizes the idea that when you're lonely, your pain is worse.
Exactly.
It really does validate that whole lived experience. So I want to go back to Dilip, and then I want to go to Dr. Gabriella Kelly-Davies, who is another person that lived with chronic pain. But first, Dilip, you're here speaking for the Faculty of Pain Medicine. Can you tell us how pain specialists, balance safe prescribing with that tension of the stigma of being prescribed pain medicine?
Yes, thank you, Coralie. And there's been some really important points being made here. And a number of parties, both Bernadette in particular has emphasised, how awful it is for someone to go with a completely valid prescription that's come out from a consultation with a medical practitioner, in my case often a medical specialist, to go to a pharmacy and get a 5-minute lecture about why they shouldn't be taking this rubbish. I mean, that's incredibly bad. And it's humiliating for people. Of course, this is actually done in a public forum. So again, there are other customers are waiting and watching and see what goes on. So from our perspective, one of the things that we do recognise, and that we were very vocal in trying to manage at an earlier stage, were some of the problems that arose with inappropriate prescribing. And the point's been made by a number of parties here that we are not going to help people with pain through one simple measure of any kind, whether it's a pill, whether it's an injection, whether it's one particular kind of manipulative physiotherapy. It's not going to work on its own. So what we do from the pain specialist perspective is we ensure that our specialists have a very broad training and a deep training in pharmacology. We also make sure that they are well aware of some of the hazards that can arise with medication. But there's another issue that we try and train all of our specialists in, and that is to listen to a patient, to hear exactly what the problems are, and also to explain to them where medicine will help, where it may not help, and where some of the hazards are. And it's like anything else, when people are properly informed, they generally make wise decisions. So the key here is, I think it's firstly a deep education in the scientific aspects of prescribing, but also being able to sit down and listen to a patient and hear what's coming from them, and to understand what their worries are. That will help tailor an explanation as to what medicines will and won't do. And it will also shape the conversation so that if things run to problems, we can actually have a properly informed conversation as to how to make it right.
I love that, Dilip. I love that that specialists are being trained in listening and teaching, and sharing, because that levels the playing field. And I think that people in pain will often say, I have a great relationship with my specialist. It's just, I go out in public and somebody says something that's silly. So good work. And I'm going to go to Gabrielle. Gabriella, we haven't yet introduced you, but you're representing Pain Australia here today, and you also live with chronic pain. And I'm curious, how is Pain Australia working to address these deeply ingrained biases at a system level? And what changes do you believe are most urgent to create a more respectful and inclusive healthcare experience?
So thank you, Coralie. Pain Australia's priority projects address stigma and bias in healthcare, which, as you said, requires sustained multi-layered efforts. We've implemented several strategic initiatives to reshape how pain is perceived and managed across the health system and society. These initiatives fall into 3 categories. The first is consumer awareness and education campaigns, collaboration with federal and state governments, and thirdly, education and training for health professionals, which we've talked about today. Pain Australia, so if we look at consumer awareness and education, Pain Australia orchestrates projects, reports and campaigns to dispel myths and challenge discrimination towards people living with pain. A recent example is the Shingle It's Not Just the Rash campaign. In February, Pain Australia released a survey and report that include consumer accounts of debilitating nerve pain and the stigma and bias they experience, including their difficulties at work. This campaign showcased real-world experiences of the stigma and social isolation faced by people who live with chronic pain. Secondly, collaboration with government. So Pain Australia's many submissions and membership of several government committees emphasise the issue of stigma and the need for education of clinicians and society. Some examples include our submissions on opioid management, women's pain, paracetamol access, and defence and veteran health. Other examples are our collaboration with the New South Wales and ACT governments on real-time prescription monitoring systems, which focused on addressing the stigma and bias faced by people living with chronic pain, when accessing prescription medications. Our contribution was formally recognised through the New South Wales Public Sector Awards and stands as an example of how consumer-led engagement can drive meaningful system-level reform. And finally, education and training for health professionals. Pain Australia's CEO regularly elevates the voice of consumers at conferences and industry forums, most recently at the Communicable Diseases and Immunisation Conference in Adelaide this year. Her keynote presentations emphasise the emotional and financial costs of stigma and ways to address it.
Thanks, Gabriella. Look, I think that you've said it very, very nicely, that this is an ongoing problem. And I want to move on to the next topic, though, which is that work is one of the things that is collateral damage for people that live with chronic pain. When we asked people how their ability to work was affected, the results were staggering. Nearly half of all people that responded had to stop working completely, and another 11% could only continue in a limited way. Managing chronic pain, as Kate has said, it's work in itself. There's a lot of hours in a day that are spent in managing pain. If you're really actively managing pain, it takes time, and that's time away from family, away from leisure activities, employment, and it's not sustainable. I'm aware that we're really competing with time here. Dilip, rather than sort of continuing on this topic, I'd like to jump ahead and ask you about the financial aspects of chronic pain, because I read recently about the cost of attending a pain specialist, and I want to know, given that we have in the survey 1 in 3 respondents saying that they spend between $50 and $100 each week on healthcare just to manage their pain, and 15% are paying more than $200 a week. And it's leading to impossible choices. Some people told us that they have to choose between food and a medical appointment. I mean, these are really significant things. Dilip, can you tell me, there is scrutiny of the out-of-pocket expenses of pain of specialists. Can you explain how you, as a pain specialist, navigate Medicare, billing gaps and patient access?
Yeah, thank you, Coralie. And if I might just add a nuance to what you just stated there, the out-of-pocket expenses for people to attend a pain specialist, they are substantial, unfortunately, and that's for the people who can actually even think of affording it. Because regrettably, a great many people with chronic pain simply can't even consider affording it, so these are our unfortunate patients who will languish on waiting lists, sometimes for years, before access to assistance. From the specific side of the pain specialists, unfortunately, something that's often not known is that pain specialists are disadvantaged in terms of the rebates that are provided from Medicare. And so it means that whilst the actual amount that a pain specialist will actually charge for an overall consultation doesn't really differ from the amount that is charged by many other specialist groups. Groups such as physicians have access to a different series of item numbers that actually gives them about double the remuneration that pain specialists get, which means that we end up with what looks like a very large gap. Gaps there because the individual remuneration for the doctor is the same, but the remuneration that comes from Medicare is only half of what goes to other groups. And that's really unfortunate. It's iniquitous for people suffering with pain because, as we've heard from many other people, the conditions are often very complex. They're medically very complex, and they've arisen in a set of circumstances where where often secondary problems have arisen, both from the physical and mental health perspective, and all of these need to be taken into consideration when formulating a treatment plan. What we encourage with our pain specialists is firstly to give the time to people, which is very important. But secondly, we've continued to advocate with government for just leveling the playing field, putting us on, say, the same playing field as a neurologist is, or a rheumatologist. Unfortunately, we're not there yet.
it's interesting, isn't it, Dilip, that what we really need is we need everybody holding hands, especially around the general practitioner. I know this is a bit left field, but the idea that we could prevent some of the really complex, awful outcomes for people in pain just by having a collaborative approach to preventing this sort of long-term failure to diagnose, failure to understand. So I want to go to Kate. We are competing with time, and I'm sorry about that, but Kate, your thoughts about the impact of chronic pain financially, please.
Yeah, thanks. I'll just touch on it quickly. It's not surprising affordability plays a big role in how you manage pain, and it's beyond just the cost of specialist. It's that choice between private and public care. For many people, that's not a choice, as private simply is not affordable. And again, we know the long waiting lists and some of the things that can happen. It's also allied health, primary care, private insurance, disability, social supports, even being able to maintain hobbies and things like that. Costs can really, really blow out. Chronic pain can also quickly push someone below the poverty line, especially if it impacts your ability to maintain an income or you have limited safety nets. We just see this kind of thing time and time again, and it's so many tough decisions that you have to make all the time.
And Kate, I'm interested that you mentioned the cost of allied health, and I'm wondering if Bernie can give us a bit of insight here, because when we did this report, we asked people where they're getting their support, and of course only a small number, 11%, are getting any help from the NDIS. There's some chronic condition care plans from GPs, there's some mental health plans, but really people are really struggling financially. So Bernie, what would it take to make allied health care more accessible and sustainable from the point of view of the person in pain?
Oh, what a huge question, and how important is it? I think being mindful of time, if I can bring it down to maybe 3 points, we need funding that really fits the condition. Chronic pain is this, multi-system condition, and we really need a system that values, as Dilip said, not just, medical, adequate funding for health professionals, but also reducing the stigma and misunderstanding that allied health is an add-on. I think, Kate, you said, we need to actually fund not just the fragmented funding and care pathways that happen at the moment, but Coralie, as you said, what we really need is to reframe pain care from reactive to preventative, and we need funding models that really value the care that works. So try to keep it as simple or as short as possible.
Well said, and I'm really interested in that preventative care aspect of what we're talking about, because there is so much unnecessary suffering that goes on because people, it takes years to really understand what's going on with your body. But we haven't heard from a very important person in this panel as yet, and that's Nicolette Ellis, who is the president of Chronic Pain Australia and doing a fantastic job. Nick, the big question, the big elephant in the room, why is chronic pain still poorly recognised in health policy? And what are we doing to change this?
Big question, Coralie, and I just want to thank all the panellists for being here today and supporting Chronic Pain Australia this National Pain Week and really bringing to light these appalling statistics. I'm sick of talking about it every year, and it's getting worse every year. And I also just really want to acknowledge that Kate's been sharing her own lived experience, which is a difficult thing to do, and she's been doing a tremendous job helping support people with lived experience in her network as well. Chronic pain is the most burdensome condition, more burdensome than mental health conditions. It costs our economy more than cardiovascular disease, diabetes, and cancer combined. So 139 billion per year it's costing our economy. The National Pain Report 2025 is the largest response we've ever received, and 65% were from rural and regional Australians, which is usually pretty unheard of in doing surveys and reports, that we have such a big response from rural and regional, and that they're doing it the toughest, really. What we're seeing when we compare the National Pain Report in 2023 and 2024 is that these delayed diagnosis, the worsening of mental health, the vicious cycle of pain, and particularly around leaving the workforce, is getting worse. So we're trending in the wrong direction. So Chronic Pain Australia is going to be at Parliament House on Thursday and talking to ministers like Rebecca White, who's also providing opening remarks there. And what we are really advocating for is that chronic pain is made a national health priority, and it's recognised as a condition in its own right, which Bernie said very well previously. So the World Health Organization has recognised chronic pain in 2018 as a condition in its own right. What that means is that we would be seen in data. So a lot of people with chronic pain say it's really frustrating that it's invisible. And for me, sitting here, it's really frustrating that chronic pain is invisible in our healthcare system. So we are not seen in the data. So whenever you're seen by your GP or Dr. Dilip Kapoor, if you're seeing a pain specialist, you're not coded as chronic pain as a condition in its own right. So that means from a system level area at the Department of Health, we are not in the data. We are not being reviewed or reported on by the Australian Institute of Health, who reports on the burden of diseases. So then we're not in the policy. And I've had the pleasure for the last 6 months reviewing all of the policies, the national policy frameworks, and chronic pain is invisible, it's absent, it's missing in all of that. If you look at PBS in the Pharmaceutical Benefits Scheme, chronic pain is not recognised as a condition, therefore a lot of the time you're not getting subsidised medications. Then you look at Medicare, it's the same scenario. So if we look all the way down, we are not in the policy, we're not in the framework, which means we're not in the funding, we're not in the research, and we're not in the services. So I'm really speaking to our community. If you can help support Chronic Pain Australia, getting in touch with your local MP. We'll be doing a lot more campaigning throughout the year. And we're having a lot of really productive conversations with the Department of Health and with the government to try and update our coding system so that we are seen, that we are visible, and then hopefully we have some flow-on effects from there.
Thanks, Nick. It's great to hear what's going on in Chronic Pain Australia, because Chronic Pain Australia started and continues to be really focused on listening to the voices of people in pain, but holding hands with collaborative organisations like those that are represented here on the panel today. And on that note, I'd like to say thank you to everybody who gave up their time to be here today and to be so focused on the person in pain and what's going on. Your time and your expertise and your insights are really valuable, and thank you. Thank you also to the audience of people that live with chronic pain across Australia, for those that are listening this morning, but also those that will listen later on today, having captured the forum today. And good luck, Chronic Pain Australia and Nicolette Ellis, on Thursday at Parliament House, where you're going to use all your influence and be holding hands with all the people here on the panel to make pain a national health priority. Thank you.